Speakers. Ksania is going to join us she's coming. She's coming. Okay, so welcome to a new session. It's a new session for IMCAS. It's a paradigm shifting female aging. So it's everything to do with menopause, premenopause. And I hope that we will have more people coming, and I'm the first speaker, so I'm going to speak about the paradigm shifting in general.
Yes, thank you, Marina. So Marina is dermatologist from Israel. So she will talk about the shift in menopause and what changed, and to explain a little bit more about this burning topic. So welcome all, and thanks for your presence.
Thank you very much, Lucia. So I think that 10th of November 2025 is going to be remembered as one of the most important days in female health in general, because this is the day when the FDA removed the black box marking on the hormonal replacement therapy, which existed for more than 20 years. So this is actually a graph showing hormonal therapy prescriptions per year. And if you see, it started in 1942, when the first conjugated equine estrogen was introduced to the treatment of female patients. You can see it's a little bit wavy, because different events affected the number of prescriptions per year differently. You see that in the beginning, constant increase. Then in 75, the connection between estrogen replacement therapy to uterine cancer was published, and then there was a decrease in the hormonal replacement therapy prescriptions. Then progesterone was added as a protective agent in hormonal replacement therapy, and since then and until 2002, there was a continuous increase in the number of prescriptions per year of hormonal replacement therapy. And in 2002, something terrible happened if you are talking about female health, because there are women initiative study has been published, and female initiative study actually changed negatively all the relationship to the hormonal replacement therapy. And there was this constant decrease since in the number of prescriptions. And actually today still there's 10 times less prescriptions given to the women of HRT if we compare it to before 2002. So this is why the removal of the black box by the FDA is very, very important. So when we are talking about the science and hormonal replacement therapy, so it's actually the removal of the black box warning it is based on the best science. So it's not like intuitive decision of the FDA. It's based on the science. And hormonal replacement therapy for women is back again. So a few words about what hormones, so sex hormones, how they produce and what they're doing for female health. The main origin of sex-related hormone in females are ovaries. They are not the only organ, because adrenal cortex also produces a little bit of sex hormones, and the fat cells, including skin fat cells, they produce female hormones. But most sex-specific changes which occurs in puberty, they are related to ovarian hormones. When we are talking about menopause, is the time in the female lifespan, which is a significant time, because with approximately 1/3 or even more of the female lifespan is in perimenopause and menopausal period. But when the ovaries stop producing both estrogen and progesterone, then this is the moment when all the symptoms start. Keep in mind, there's still some hormones produced by adrenal glands and the fat cells. There are still, that's different hormones, but they're sex-related hormones. So a little bit for definition, because we need to speak the same language. What is the definition of menopause? It's only when there is no menstrual activity for at least 12 consecutive months, and there is no other reason for that. For example, if there is a ovarian operation, removal of ovaries, so women are not expected to have any menstrual activity, and it's not necessarily related to the natural menopause. Now, there is a very significant period that is called menopausal transition or perimenopause. And this is the time between the onset of irregular menstrual cycles due to the fluctuation in the hormonal levels and the beginning of the menopause. So this is something that you need to keep it in mind, the definitions of menopause and perimenopause. The average age of menopause worldwide is around 51 years. So everything menopause that starts before 45 is defined as early menopause, and if the menopause occurs before 40, it's premature ovarian insufficiency, and it occurs in approximately in 1% of women. Now, the symptoms associated with menopausal transition affect more than 80% of women. And they are ethnicity associated. They are different in different places in the world. We'll speak about it a little bit later. 1/3 of the women suffer a lot. It's the significant severe symptomology. Some symptoms are transitory. They subside spontaneously, while the other ones persist and even worsen. So what are the main symptoms? The vasovagal symptoms are, I think, the main menopausal symptoms that affect female quality of life. They are more common in Caucasian women than in Asian women. It used to be related, at least they thought so, to the diet, like soybean, that can be comparative to some estrogen-like compounds, but I think that currently it's not the line of the idea. So they, as I mentioned before, impair the women's life very significantly, and they are related to the changes in thermoregulation and central nervous system, because this is where the temperature center is located. In most of the women, they are transitory. So after 6-10 years, they disappear, but in up to 15% of women, they persist and they continue all life. Second, very important, the vasovagal has something to do with the skin. It's not only. Now, genitourinary syndrome, again, it's gynecological, urological, but also skin-related. It's due to vaginal dryness, burning, irritation, dyspareunia, recurrent UTIs. Affects about half of the women, and they're related to the thinning of vaginal mucosa and change of the pH and microbiome of the vagina. So it's a very important syndrome which affects female quality of life. Osteoporosis, as probably all of you know, women can lose up to 20% of their bone mass in the first 5 years of menopause, because estrogen is a natural inhibitor of osteoclasts. Osteoclasts are the cells that actually degrade the bone. So when the osteoclasts are not inhibited anymore, they start actually to degrade the bone. And 50% of patients will experience osteoporosis-related fracture until the age of 50. So it's a significant number of patients. And again, menopause has also psychological and cognitive changes. Words like brain fog, mood swing, all the menopausal women are a little bit crazy, irritability, worsening of anxiety, depression. In my practice, I think that 50% of menopausal patients or women, they are on psychiatric drugs because of this, the psychological side of menopause. And of course, cardiovascular health, increase of bad cholesterol, increase of metabolic syndrome, weight, adiposities, diabetes, hypertension, and cardiovascular morbidity in general. So what about the skin? As I mentioned before, skin is kind of endocrine organ. First of all, most of the cells in the skin, both keratinocytes and fibroblasts, they have estrogen receptors, and we are talking about estrogen receptors alpha and beta, two different ones. So when the menopause occurs, there is a reduced systemic estrogen level to the diminished ovarian synthesis, as I already mentioned, but not only that, menopause causes a decrease in expression of estrogen receptors on the skin. So the skin becomes more resistant to estrogen. In 1940, there was a publication of clinical observation that the skin is getting thinner in patients with osteoporotic fractures. Look, it's almost 100 years ago. And then in 1967, there was a publication that thinner and fragile skin is more common on postmenopausal women. So the understanding that skin is affected by menopause, it's very, very old one. And it took us so many years just to start talking about menopause and the skin. So look at it, this is from Sonia Sattler's publication. It actually shows everything that's happening in the skin during menopause. The epidermis is affected, the dermis is affected, blood vessels are affected, the fat cells are affected, everything is affected. So what are clinical expression of all these changes? First of all, menopausal women suffer for dry skin. So it's not only age. It's not like men suffer less of the dry skin. And it's due to the impaired skin barrier function. There's increased impaired wound healing because of the decreased antioxidant function of the skin. There is, of course, decreased collagen and elastin synthesis, and we can see the dermal thinning and the wrinkling. There's decreased glucosamine glycans and extracellular matrix in general production. Again, skin turgor decreases, less sebum production, and of course, it affects the hair growth as well. And you can see here the graph, and you see the correlation between the estrogen levels, which drops around the age of 50, in parallel with very significant acceleration of the decrease in collagen levels and elasticity of the skin. So the connection is beyond any discussion anymore. Now, a few words about the hormonal replacement therapy. Now, the current recommendation is to start HRT before the age of 60 or within the first 10 years of menopause. The Women Initiative study, the one that has been published in 2002 and changed negatively all the relation to hormonal replacement therapy, they included women who were 15 and more years after menopause, so the hormonal replacement therapy was not effective on them. So it's important to start it early enough. So estrogen is the primary hormone which is needed to relieve the hot flashes, the night sweat, the vaginal dryness. It offers protective benefits of the bone and cardiovascular health, while progesterone, keep in mind, it's only for uterine protection, because if we give estrogen, we affect the uterus. The mucosa started to proliferate, it will increase the risk of uterine cancer. So we always, unless the woman does not have uterus anymore, we always have to protect the uterus. And then sometimes we discuss the testosterone role. Again, it's sexual hormone, but it's not a female sexual hormone. It affects the libido, the brain fog, extreme fatigue, that some patients experience even after taking the traditional hormonal therapy. So we'll discuss all these three hormones. Now, skin changes, unfortunately, currently are not indication for hormonal replacement therapy. But I will start discussing, and maybe in 10 years I will give you another new breaking news by FDA. But currently we are discussing all of it a little bit off-label. So when we're talking about hormonal replacement therapy, the hormones can be delivered orally, they can be delivered transdermally by patches, sprays, and gel. They can be delivered locally, creams, and combinations of all of the above. And again, it's above the scope of this presentation, but there is a place for all of them. What are the proven skin effects of hormonal replacement therapy? It increases the collagen contact. It was found in at least one of the studies that regarding the collagen contact, actually the topical, the transdermal collagen, transdermal hormonal replacement therapy did better than oral, but it's one study, and it increases the skin thickness. All of this proven by studies. So currently, in '97, there was publication of the first natural health and nutrition survey, which included almost 4,000 postmenopausal women, which was a very big study. The age of the participants was above 40 years, and age after menopause in the frames of 10 years, it's 9 years. So they found that hormonal replacement therapy is significantly improved the dry skin and wrinkling, and it was a very important finding. Now, what about topical estrogens? They can be given, as I mentioned before, by patch or vaginal cream. The advantage is there is a minimal, when we're talking about skin, minimal systemic absorption. So when we're talking about systemic complications of hormonal replacement therapy, the patch is safer, and it also showed the effect, positive effect in skin collagen, hydration, and elasticity. Now, when we're talking about other options like plant-derived estrogens and some substitutes, there are not enough data to support. There are some small studies that are supporting it, but we are not there yet to mitigate this treatment. And remember, none of them are approved. There are some cosmeceutical products integrated in the skincare products that show a little bit of efficacy, so we cannot claim that it's fully effective. Now, what are the main challenges? So currently, skin problems are largely neglected by physicians compared to other symptoms of the menopause. It's not clear which hormonal replacement therapy is more favorable for the skin, whether it's systemic, topical, skin only, which is more safe. There is no study comparing systemic and topical estrogen after anti-aging treatments. Can we achieve the best outcomes using our traditional anti-aging? Whether we do better if we combine hormonal replacement therapy with other intervention. So, and does hormonal replacement therapy increase or decrease the efficacy of this treatment? It makes sense to combine, but keep in mind, nothing is proven yet. Thank you very much.
Yes. Thank you, Marina, for this good insight. So I will continue the discussion. I don't need it. I'm too tall. On n'a pas de pointeur? Oh, you understand French. Okay, so I'm Dr. Lucia Hufontaine, so I came from Paris. I'm an endocrinologist. So today I will speak about physiology in menopause. And menopause is one day, so maybe this one day is not an ending point, but maybe more a turning point, and an opportunity for aesthetic medicine also to provide some help for those women. So we are discussing today why understanding menopause is important in aesthetic medicine. So just 2 slides of physiology. So female physiology evolution from the birth to the end. We have the ovarian reserve. And as you can see, at the age of puberty, half of the reserve is already declined. And with the evolution of FSH and LH, you can see also the contrary evolution of the ovary reserve. And the ovaries are the powerhouse of the estrogen production. That's why it's so important. And in the early 30s, you also already have a decline in the ovaries production. And I advise you in your practice, if you want to see a little bit more about the ovary production, to make the biomarkers inhibin beta, because it's a good reflect on the ovaries production. Inhibin beta is better than AMH. So what's happening during this period that is so complicated to understand, the perimenopause, that could last from 1 year to 10 years. And what's happening is we have a lot of fluctuation in between drop of estrogen and sometimes peak of estrogen. And what is also really interesting for you to know is each woman will have a specific profile. It really depends on the woman, because some women have a lot of estrogen since the puberty. So if you have a lot of estrogen, you also have a lot of receptor. So during the perimenopause, you could have like more symptoms and sometimes harder than the menopause because of the overactivation of estrogen. You know that in every field, the body just like homeostasis, stability. So sometimes excess or deficiencies can create the same symptoms. And what we know is that we have two phases in perimenopause: early perimenopause and late perimenopause, when the estrogen begin to drop. So we mentioned that before, menopause have a scale, and now I think we are going to enrich the scale also. So then you can have these symptoms in mind just to measure the severity on the onset of menopause. So you will have psychological symptoms with hot flashes and sweating, and also some somatic symptoms with muscle and joint pain. Most of the time, it's one of the most important symptoms is joint pain, and it does mark the early onset of menopause. And we will have also urogenital symptoms, but we mentioned it before. And yes, I just want to make sure for you that menopause is just 1 day, okay? So the period before is perimenopause, the period after is postmenopause. So why is menopause so important? It's because it creates like a tsunami, like an internal shift at hormonal level. Look, where is the pointer? Here. Okay, so we have like receptor to estrogen like everywhere. And it will concern bones, joints, cardiovascular, metabolism, central nervous system, psychological sphere, skin tissue, and also sexuality function. Why nervous system? Because estrogen does activate, does have receptor in the prefrontal cortex that allow people to have response and not reactivity. That's why during the onset of menopause, people just complain about irritability, like I can't bear anymore my colleagues, you know. It's just because of this prefrontal cortex. And also because progesterone is a good activator of GABA systems. And also what is really interesting is, as you can see, we have two types of estrogen receptor. So keep in mind that receptor alpha does have a function of proliferation, and receptor beta, contrary, anti-proliferation. So it's really interesting because in the fat tissue we have both. So we don't really know which one will be activated. So when women have too much estrogen, could also activate the proliferation of the fat tissues. But when you miss estrogen, you have like a huge deficiencies. You could have like an underactivation of receptor beta, and so also like an activation of the fat tissue. So one slide regarding the vaginal microbiome, because it's really interesting to know that it's really the contrary to gut microbiome, because in the gut microbiome we have like a large population, and what is important is the complexity of the microbiome. But in the vaginal microbiome, the most important thing is the selectivity. And we know that estrogen will boost the epithelial maturation and proliferation, that will lead to a glycogen accumulation. And thanks to this glycogen accumulation, we will have this low pH that is really important for the vagina. And with high pH, it will shift towards another population in the microbiome, and it will cause the dryness, irritation, and the fragility atrophy of the vagina. So really important maybe also to work on the microbiome before the onset of menopause. So right now, let's talk about skin, because we are at IMCAS. So as you can see, the estrogen deficiencies will have effect on all the dermal units, from the epidermis to the vascularization. So regarding the epidermis, why? Because we have an effect from estrogen for the proliferation of keratinocytes, and so it will cause a thinning of the skin and also a skin dryness and a disruption of hydrolipidic barrier. And we will have also an impairment of skin renewal, and we will have a decrement of collagen fiber 1 and 3, 30% in the first 5 years, like 30%. After the 5 years, it's only 2% per year. So those 5 years are really important. We will have an effect on vascularization because of the stiffness of the artery, less impact from progesterone and testosterone. And I'm not a big fan of using testosterone because, as you know, we have an enzyme that converts testosterone to estrogens, and some studies also mention that using a testosterone could also activate estrogen in the breast and could cause some risk. So progesterone could be also interesting for the premenopausal seborrhea. So it could be like a good cue for you to maybe think about perimenopause at this stage. And also because of acne, like outbreak. So skin aging, as I mentioned before, a post-menopause age is really more important than chronological age in aesthetic medicine. So we will have a critical window of these 5 first years of menopause onset. And as you can see, it's also an opportunity for you as a medical doctor specialized in dermatology, gynecologist, or using aesthetic medicine to create a really personalized protocol. So just this slide to mention that we will also have a tendency to change the ratio in between collagen type 1 and type 3. And we will have a ratio above like 1:1, and it's not normal. And it will create a tendency to have a more laxity and fragility of the skin. So what are saying the studies? So yeah, let's correct everything and using hormone replacement therapy, so then we can have a beautiful skin, no? No. Yeah, it was a good hypothesis, but right now the main studies, but it's a main studies, so we're still waiting for new studies. So the KEEP studies didn't mention no significant benefits on wrinkles and differentiation on the skin appearance. But in the observational studies, they mention improved skin aging and thickness. So I think in the future we will have more data to think about. So just this slide for some reflection, because as you can see in the studies, using mouse to create like an ovariectomy, just to see how it does accelerate the skin aging, and also the fragility of the skin and the tendency also to age faster when exposed to UV. And we see that ovariectomy alone is sufficient to accelerate skin aging and increase the UV sensitivity, and with a decrement on elasticity and marked sagging, just with ovariectomy. So also important for our patients in their like 20s or 30s to think about when they're undergoing this kind of surgery. So yeah, you want a baby skin, but remember it exists before estrogen. So this slide is really interesting because, yeah, a baby doesn't have estrogen. So, but a baby, we all want the baby skin. Uh, yeah, because what is particular in the baby skin, we have a huge natural moisturizing factors and huge quantity. And we also have no cumulative stress factors such as UV, glycation, and oxidative stress. So the beauty of the skin in the baby is mainly because of the integrity and the absence of damage. And with puberty and the impregnation with hormones, you will have a beauty by hormonal support that will have the tendency to produce keratinocyte, collagen synthesis to activate the support of the skin. So during menopause, you have everything. Like you don't have the hormones to support you, and you have the accumulation of stress factors such as UV, glycation, and oxidative stress. So that does create the difference. So working on hormones, yes, but work on what does exist before the hormones, such as protecting the skin from cumulative damage. So the equation for skin aging in menopause could be environment, tissue architectures, and inflammaging. Hormonal status is a coefficient. Okay, they are a modulator of the skin, but they don't create the change. So just one slide, because I think we are going to speak about it later. So what could be the main protocol in aesthetic medicine is maybe to prepare the skin in perimenopause using biostimulators and also some HA supports. And during menopause, maybe could be also to target the regeneration and to preserve what already exists and to boost the collagen. And in post-menopause, it will be more focused on correcting and restoring the volume using surgery or HA fillers. But what is important for you to know is that even if the skin is aging and you want to increase the parameters in like energy-based device, just don't. Because the skin resilience at this stage is really low. The skin is not able to repair as usually, you know, because the collagen is declining. So if you rely on the collagen production from your patient, it's not here. So better to use biostimulator before any energy-based device to prepare the skin to respond better. And that's it. So just one slide for supplements that could be useful during menopause. So omega-3 for this anti-inflammatory impact and for the quality also of the brain health. I advise like more than 1,000 of EPA for the quality of the brain function. Omega-7 is really important also for the quality of the skin, for the mucus, for the hair also. Vitamin D for the bones, Q10 for the antioxidant, 200 milligrams could be great, magnesium for sure, and it depends on the focus. Bisglycinate for the sleep, threonate for the brain area, malate for the detox. For sure, detoxification of the liver really important because we have a lot of residue of hormones inside the liver. So if you want to prepare the body to accept HRT, just detox the liver. It's really great. Using calcium deglucarate is a good way also. And for sure, to work on resistance to insulin. So just one slide on further hypothesis regarding the skin and menopause. We know that we also have a steroid conversion on the skin, so it could be a target using the steroid on the skin to maybe increase the transmutation in estrogen. We know that there is also a strong correlation with HPA axis with the stress response. And also we have some idea about also the elevation of LH that could also increase the senescence pathway. So thank you for your presence, and yeah, despite enthusiasm, skin is not uterus. Thank you so much.
Thank you very much. Thank you very much. I think you started a lot of new ideas. I just wonder, Ksenia, please come up. I just wonder, because I think it was never assessed, whether when we're treating patients, with aesthetic treatments, whether the patients on hormonal replacement therapy will have more prolonged results than patients without.
Yeah, it could be a good idea.
Yeah, I think it was not assessed, but I think. Okay, so our next speaker is Ksenia Sofra-Weiss, and she is going to speak more about hormonal imbalance and dysbiosis, why women suffer and why they don't have to.
Okay, thank you, everybody, and thank you very much for having me. We have a special guest here, Dr. Cartier. I took the liberty to add andropause because a lot of female issues are interrelated to what happens to men during menopause. I have no conflicts of interest. I'm just basically talk about science and new ideas in science. And this has been based on Science Review of 380 articles. And also my books, there's a lot of references, obviously, included in the books, 73 articles, and my books have been translated in 12 different languages. And a lot of clinical studies that have been looked at and involved. Now, the history is really repeating itself, and we're still talking about menopause and how we can resolve these problems. And the most important menopausal symptom that women hate is the agony of this vaginal dryness that basically interferes with relationships because it interferes with the sexual part of the relationship. That vaginal atrophy and the burning sensations that women have that basically stop not interfering with the male. Men also go through a midlife crisis, and because women are unresponsive, they go out and buy a new car. But estrogen, we're talking about estrogens, is not the only problem in menopause. It's one of them that has to do with the thinning of the skin, but there are other problems. And the other problems is that a lot of patients say, my hormones are in the normal range. Why is it, there's no problem. But it's not just the normal range. It has to be optimized. It's the optimal range. And if you look at the numbers there is a difference between normal range and optimal range. And that, I think, is very important. And then you have this inflammation that is both for men and women, and inflammation will create apathy. Apathy is going to get men and women distancing themselves from each other. Low testosterone is going to lead to boredom, both from the female and the male. And again, it will interfere with the relationships, the psychological aspect of menopause and andropause. And of course, high cortisol is going to get women to eat more. Of course, they're going to put on more weight because they're eating more. And men are going to just start going out, getting some more girls in the new car they bought. And all that is going to start interfering. So men are also going to go to the gym, and they're going to keep working out to kind of get back their youth. But the problem with that is that cortisol and testosterone have a kind of seesaw relationship. So when testosterone goes up, cortisol goes down. So they basically, with a gym, they increase the cortisol because they expand energy. And after 50 years, the visceral fat is not dissolved, and they expect to get the one on the right, but they get the one on the left. Basically, the muscle is built on top of the visceral fat. And visceral fat, I call it death by visceral fat. Why? How many people do you know over 80 how many people do you know over 80? Not many, right? But they die. That's why. So, and the visceral fat is the beginning of a lot of problems. So Again, the problem is not just going to the gym. If you think about it, somebody with IGF deficiency, they don't grow any muscle. So the point is not going to the gym or running, and it's a lot more important that it's the hormones, and that is the most important thing. So a lot of the understanding so far in anti-aging is that the body is like a glass that empties, and then you have to put more in it. So you put more injections, you put more exosomes, you put more stem cells. But the body is interactive. So why is it that menopausal women cannot lose weight? They go to the gym, they do the due diligence, because fat is a systemic issue. It's a systemic problem. And this is what I would like basically to gear your attention and your focus today on the systemic synchronization. Because when the system is synchronized, there is a lot of good things that happen out of that. So it's not just being in the average range, and of course, if it's low or high, it's important. It's because too little insulin, you gain weight. With too much insulin, you still gain weight. So that's no solution. Too little leptin, you're starving. Too much leptin, same thing. Again, you're starving. So it's the optimization of hormones. It's not just, more is not better. And this is something that is very important for us to understand. Why? Because hormonal imbalance and lack of optimization is going to lead to sadness. And you can have sadness with anxiety or sadness without anxiety that is actually pleasant. So we can transform stress into strength through a synchronization of the body. And there's a lot of different techniques and methods that can do that. It's not just one or two, there's many. So it's your choice to start looking at synchronization. Now, another main issue in menopause is the gut. Okay, the dysbiosis, the gut imbalance. And if you can have rich bacterial communities, and you can have a poor and unbalanced bacterial communities. One is going to be healthy, the other one is going to be unhealthy. And the gut inflammation, hormonal imbalance go hand in hand. They actually have the exact same symptoms, and they're all related to energy, because the energy is going to go down, both with gut imbalance and with hormonal imbalance, overall health, and of course, the mood is going to be a problem. And what happens is a vagus nerve that connects the gut with the brain. And there is, we call it the gut-brain axis. Well, this is very important because the brain makes a lot of determination about how we feel, how we react, the decisions we're making, how we're going to respond to our relationships. And the gut produces about 90% of serotonin. Serotonin is related to every single mental health disorder, anxiety disorders, even schizophrenia. It has to do with serotonin issues. So the involvement of, we even say things, we say, I feel it in my gut. We have these expressions, or butterflies in my stomach. This is basically, the gut is like your second brain. So brain and gut are intertwined. And of course, the immune system are also part of this. So you have this triad of 3 different factors influencing. And this is what I've been talking about in my book, The Rhythm of Youth. I gave a copy to Dr. Cartier. Basically, what I say in the book is that when you synchronize in the body, something magic happens, and that's a gestalt. And the gestalt is more than the sum of its parts. So even if you treat different parts of the body, it's not going to create that. It's the synchronization that matters. The rhythm of youth, you see, the person, that when you have like an awkward way of moving, and when you are having that rhythm inside your body, because you're synchronized, you have a whole different movement. Your movement is different, your presentation is different. So basically, you can unlock longevity through A-powered synchronization. Now, if you look at the nervous system, it's a field. Any book you look at the lymphatic system, it's also a field. It's a field of energies. The fascia system, it's also a field of energy. So the body operates as a complex network of interconnected energies and fields. It's fields. You need to understand the body as a field, not just arm or liver or gut, but something that all of these organs are interrelated and interconnected. So what you see here is a movie basically from interacting through resonance, through understanding the fields and creating something that can interconnect the fields. And you do that with different technologies like resonance energy transfer, was invented in the 50s, thread synchronizing energy transfer. So health is synchronization. That's the main, basically, perspective that I would like to get you to kind of understand here. A synchronized body is a vigorous body. It's not just healthy, it's full of energy. So the key, I think that according to my opinion, my perspective, is, and please challenge me if you would like, I would like to be challenged, that it's a matter of resonance. There's natural resonances in the body. And resonance was invented in the 50s by Foster, resonance energy transfer. And basically, all of our research is looking at different effects of how resonance affects the fields inside the body. So a resonance is like a chain reaction inside, and they're inherent resonance inside the body, that if we tap into these resonances, we can then synchronize the entire system. Even with exosomes and stem cells, resonance is like the cable that basically the stem cells or the hormone replacement therapy that kind of are the cable cars that can be transferred. You're going to need the resonance. The resonance is like carving highways, and when you have highways, you have a much better, a more advanced city. It's the same thing with our bodies. When everything is interconnected and communicating, then you have a much healthier body, like a better city with more highways. So you have, and also you have a thread language, that we call it like a resonance language inside the body, which is inherent just inside your body already. And basically it involves the brain, and it has its own language. And that's what I was doing in my book, The Rhythm of Youth, trying to find what is the language that the body speaks, kind of thing. And when we have this hormonal optimization, again, we have in healthy gut, and we have confidence at any age. Detoxification is extremely important. That's another aspect that I would like to bring up today. Toxicity, free radicals are going to break DNA. They're going to increase aging. And of course, inflammation. There's a lot of things that create, they increase inflammatory processes. And through this resonance synchronization, you can have, we did some research on that, and we looked, and it was like a 36%, about 744 subjects. Also, it balances hormones, so your hunger is going to go down. You're not going to be as hungry. And your metabolism is going to have a boost, and you're going to increase energy. The energy will increase, and we had some studies on that, some of the studies that I was involved in. Stress is very interesting because it's not just cortisol, it's the entire synchronization and optimization of the system. It's like a tune-up of the entire system that will reduce that stress. And it will rewind your biological age when you have a technique that synchronizes the system. And we had from 49.7 people, biological age was 32.9 years. So there was a synchronization. And youth hormone is not going to decline. The reason why aging is lack of synchronization. That is why aging is occurring. I mean, and we can delay it by resynchronizing the body. And of course, as we're aging, we're going to desynchronize and try to synchronize again. But this is, I think, a new way of understanding aging and anti-aging. Youth is more than appearance. We need to look at the inside. Longevity is about understanding what happens inside our bodies and how we can bring all those connections back to be reconnected. If you have any questions, you can reach me at science@aelios.com. This is my WhatsApp. If you would like to take a picture, any questions, just let me know, and I will be there to answer it. Thank you very much for inviting me and
Thank you.
for listening to this lecture.
Thank you so much. Thank you so much, Zagna. It was really interesting insight. And as you mentioned, like the most important things in the body is the flexibility, the ability to coming back to the neutral point. And so now we are going to welcome Irina from Italy to speak about thread lifting in postmenopausal women. Thank you, Irina.
Good afternoon. Thank you for your presentation. Thank you for being here. From the previous presentation, I've understood that for doctors, it's a real challenge to help women willing to maintain youthful phase. And in my presentation, I would like to try to understand how can we do it with absorbable threads. When we talk about menopausal phase, we are not describing a subjective impression. We're describing a reproductive clinical phenotype characterized by horizontal tiring of the facial tissue, particularly in the mid-face, jowls, and submental region. What is critical is that this phenotype develops rapidly after menopause, and it's not simply the result of cumulative chronological aging. In my experience, and supported by literature, this is a gender-specific postmenopausal structural transformation rather than a gradual aesthetic decline. This distinction matters because if we misdiagnose the problem, we mistreat it. So, as previous colleagues already explained, estrogen is a central regulator of dermal homeostasis. It directly influences collagen synthesis, elastin organization, and hyaluronic acid content. And it plays a key role in maintaining skin integrity and mechanical support. After menopause, collagen loss accelerates dramatically. And as already Dr. Lucy said, that up to 30% of collagen is lost within first 5 years after menopause. And this loss is not superficial. It affects the deep connective architecture of the face, so leading to structural reorganization rather than simple wrinkle. That's why surface-focused treatments alone consistently underperform in this patient population. The menopausal phase results from the failure of 4 interdependent systems. First of all, collagen decrease, weakening extracellular matrix. Elastin, compromised, already reduce elastic recoil of the skin, creating permanent sagging. Then, weakening fascial support and also retaining ligaments create difficulty with maintaining the face shape. And then fat compartments descend and reorganize, accumulating mainly in the jowls and the submental area. So clinically, this manifests as heavier, more mobile tissue rather than simple volume loss. And in estrogen-depleted tissue, increases ptosis and laxity, challenging conventional rejuvenation treatment, and as consequence, also conventional thread vectors. So anchorage becomes unstable, and the results are short-lived. So this is where material science becomes clinically relevant. compared with PDO thread, PCL-PLA threads offers superior tensile stress, elasticity, and significantly longer reabsorption period, up to 24 months. This prolonged presence along sustained biostimulation and not simply mechanical support. NAMICA technology, the new generation of threads, create from this passive scaffold active delivery platform. By incorporating native hyaluronic acid with a particular sophisticated technology into micro, submicro, and nanocapsules, we can release native HA up to 6 months by controlling the shell thickness. This is particularly relevant in menopausal skin, where hydration loss, inflammation, and impaired fibroblast activity coexist. So the goal is not only volume replacement, but biological support of the tissue recovery. So it works through triple action mechanism. First of all, of course, we have mechanical support. Barbed threads, they anchor the subcutaneous tissue and fixate it in optimal position, aesthetically optimal position. And so we already obtained a better face shape. Then we have prolonged biostimulation due to slow, gradual release of hyaluronic acid up to 6 months, as I said, which reduce inflammation and stimulate dermal fibroblast for better collagen production. And remember, polylactic acid, this is very powerful stimulation of collagen production. So we stimulate collagen production up to 24 months. Success heavily depends on patient selection and planning. Our ideal patient is healthy, not smoking lady with moderate ptosis and adequate both support. And be very careful with patients with a lot of sagging skin, very thin skin, and all other contraindications we have. I also advise you to be very careful with a patient with unrealistic expectations from thread lifting. I briefly show this slide, but for me it's very important to underline that nutritional foundation supporting the thread treatments is very important. And without that, proceeding with this treatment is essentially ineffective. And the same for hormonal therapy, where indicated, as previously Dr. Marina asked if we can expect better result with patients in menopausal treatment. Yes, in my experience, we have better and longer lasting results. We can improve and optimize our outcomes with synergistic therapies. Of course, I agree with Dr. Lucia, start with biostimulation, support amino acid therapy, and afterward collagen stimulation, and afterward thread, so we can optimize our outcome. My treatment protocol always starts with structural clinical evaluation. This is very important. So I assess first skin quality. I check if the skin is too thin, if it's creepy, and so on. Then ptosis mapping to check where we have exactly vectors of gravitational ptosis to understand if the threads alone are enough or I need to support with some other therapy. And then I evaluate tissue mobility to understand which kind of thread I should use and with vectors. This three-step assessment is what turns threads from generic procedure to a predictable long-term strategy. The menopausal phase cannot be addressed with a single lifting vector. Each tier of ptosis must be addressed independently. In the mid-phase, vectors are anchored to the deep temporal fascia to reposition malar fat pad. In the jaw area, vectors engage Lohr's ligament and platysma auricular fascia. and in the submental region, deep anchoring to the mastoid connective tissue helped us to recreate cervical mental angle. Preoperative planning is very important to prevent migration and also to ensure stability. In my practice, I use dual layer technique, so 2 layers. In the deep plane, barbed PCL-PLA thread, which reposition fat compartments and provide mechanical support, and in the superficial plane, smooth or screw type threads to create dermal scaffold. This approach combines immediate structural correction with progressive dermal redensification. So the goal is not overcorrection, but supporting correct fascial architecture. So I present some cases, but remember, these cases illustrating just adaptation, not idealized outcome. Each patient presented different estrogen depletion, different tissue heaviness, and prior treatment. The objective is to obtain a natural outcome which lasts up to 12 months at least. This is the aim of this treatment. So this first 54 years old patient, 18 months post-menopause, smoker. Clinically, she presented, as you can see, with mild jowls, but very heavy nasolabial fold and marionette lines. This is a typical early postmenopausal structural pattern. The main challenge in this patient was the laxity of her subcutaneous tissue. That's why I increased the number of threads, and in this way, I treat her in appropriate way. Remember, treating menopausal phase with not enough product is a cause of early relapse. And you can see this is result at 12 months. The lifting effect, of course, is attenuated, but the contour is still maintaining and the skin quality improved. Another case, totally different scenario, a more advanced menopausal phenotype, 64 years old, 8 years after menopause. So 8 years of estrogen deprivation create heavier tissue, they are less elastic, and of course less responsive to mechanical lift. That's why I prepare the patient in advance with different treatments, in particular with amino acid biostimulation. I like it very much because it rejuvenates our extracellular matrix. So this improved the skin appearance, skin quality, but the face shape remained alterated. That's why I chosen very strong bidirectional threads to address jawline, and particularly spiral thread to address vertical collapse in this patient. So they see the result after 12 months, and I think the patient was very satisfied, and I think it's a good result. And the last case represents another different scenario, a 58 years old patient, 3 years post-menopause. Her main problem was not laxity, but elastosis. So her skin is tough and very difficult to penetrate. That's why, in this case, as I previously said, we need to combine treatments in order to provide better outcome. I inject her with PLA and afterward insert the thread enriched in hyaluronic acid in order to create better biological tissue. In fact, the patient was very happy, and the result at 12 months, I think, very satisfactory. So in menopausal patients, we have to talk openly about durability. Estrogen deficient skin simply does not anchor the threads the way the younger tissue does. Typically, the mechanical lifting effect lasts about 6 to 9 months. What can last more? This is biostimulatory effect, which provides effect for 12-15 months. What does it mean from clinical point of view? It means early maintenance, adjunctive collagen supporting therapy, and the most important, patient education. because predictable longevity and realistic expectations are the foundation of long-term patient satisfaction. To conclude, the menopausal phase is not simply an aesthetic concern. It's a hormonally-driven, structurally mediating aging phenotype. Treating it effectively requires understanding the biology of postmenopausal skin, choosing appropriate skin material, appropriate vectors, and specific strategy. When mechanics and biology are aligned, thread treatments can move from temporary camouflage to meaningful structural support. Thank you very much for your attention. Thank you.
Thank you very much, and thank you for being on
Thank you,
time,
Elena.
so we can proceed with our last speaker, Dr. Oravi Chintakanan, and she's going to speak about the vaginal rejuvenation.
Thank you for having me here. So it's quite different from like my work. So I'm urogynecologist working here in Bangkok, Thailand, and from Mahidol University. So yeah, my colleagues already like give you a background of like the menopause look like, and so my part is about vagina. Okay, so let's go through like why is impact after menopause. So after estrogen levels drop, is effect inside vagina and also urinary tracts. Previously, you already saw like the picture that estrogen receptor is inside vagina too, right? And it's also inside the bladder. So after the menopause, the estrogen, both estrogen level and estrogen receptor drops. So it causes you to have vulvovaginal symptoms. So the epithelial of the vagina is thinner, and the pH normally, if you're younger, the pH is like very low. However, after menopause, the pH is higher, and the rookie and the lubrication is lesser. For the urinary tract, it can cause you to have urgency, frequency, urinary incontinence, and also the recurrent UTI. And for pelvic floor, it can cause you to have vaginal relaxity, and it can cause you to have sexual dysfunction. So previously it's called vulvovaginal atrophy, but right now we like changed the term to genitourinary syndrome of menopause. So it affects like 27 to 84% of postmenopausal women, and 80% are undertreated. So spectrum of the GSM is included genital symptoms like dryness, irritation, burning, itchy, loss of elasticity, and rookie. In terms of the sexual function, it can cause dyspareunia. It means pain during sexual activities, vaginal laxity, and reduced satisfaction or distress during sexual activities. And for the urinary tract, it can cause urgency, frequency, dysuria, recurrent UTI, and urinary incontinence. So why estrogen is necessarily? So the local estrogen is mean that we put inside vagina. So it's different from the HRT because for the HRT, you can apply like to take orally or the patch or the cream that you apply outside. But for vaginal estrogen or local estrogen, we put inside vagina. So it can be estradiol or estriol. It can have like many forms like the cream, tablet, ring. And other options like the HEA and other things, so I will not touch that. So the good thing of the local estrogen is less likely absorbed into your bloodstream. It means that it's lesser risk in terms of the systemic. And for the breast cancer survivor, it's still option. So you have to discuss with the oncologist whether it's okay to use. Okay, this is a recommendation for the GSM. So most of the guidelines recommend that vaginal estrogen is safe and is recommended for the moderate to severe of the GSM. And for the urinary tract symptoms, it's also recommended as well if the patient have the LUTS or lower urinary tract symptoms that related to menopause. Okay, this is my work. This is, we use the local estrogen and take a look with the urine microbiome in postmenopausal women who have overactive bladder. So we just present at the IUCA in Brazil. And for the local estrogen that we use E2 vaginal tablet. And we collect the urine sample from the patient and take a look at the microbiome. So it tells us that the number of the lactobacillus is increased after using the vaginal tablet. And it's also improved in terms of the lactobacillus diversity. And another thing that we found out that Ganarella is kind of play an complex role because it's increased in number who like having better OAB symptoms as well. Sorry. Okay. So it means that if patient have the GSM and the OAB symptoms, local estrogen is like play an important role. So if you like treat the patient who have GSM for a while, so like the last 10 years, the thing that is come up like more evidence is about the energy-based devices. So what we can use from the energy-based device, we can use in terms of many indications like vaginal laxity, for tightening, for stress urinary incontinence, for GSM, for sexual dysfunction, and also for external vulvar rejuvenation. Okay, and how does this work? Basically, for like every type of the energy-based device, so it's divided into laser treatment and radiofrequency treatment. For the laser, mostly it's like fractional CO2 laser and erbium YAG, and for the radiofrequency, so you can divide it into monopolar, bipolar, fractional bipolar. All of the energy-based device have the same theory, so it can produce heat, and so the optimal heat will stimulate the collagen production and synthesis, and also neovascularization. And then the tissue will be thicker. Okay, so however, the evidence is still like not enough for us to tell whether it's benefit for the patient. That's why we need more study and long-term follow-up. And this is my work as well. So I this is the fractional CO2 laser. We would like to see whether after we use the fractional CO2 laser in postmenopausal women who have GSM, whether it's going to change any vaginal environment or not. We take a look at the lactobacillus inside vagina. And this is the prevalence of lactobacillus. You can see the number of the lactobacillus is increased after the treatment. And this is the symptoms. We include the vaginal symptom severity index and the vaginal flora prevalence. So you can see that the symptom is much better, and in terms of the vaginal microbiome is improved as well. And this is another of my work. I use the monopolar radiofrequency and for treat the stress urinary incontinence. This is the RCT comparing the treatment group versus the sham group. And for this paper, I include only postmenopausal women. So if you take a look at the outcomes, so the primary outcome is 1-hour pad test. So what we do for 1-hour pad test, we measure the weight of the pad first, and then ask patient to wear that pad, and then drink plenty of water to have like kind of full bladder, and ask patient to do activities for 1 hour, like jumping, go up and down the stair, and then, yeah, whether she leak or not. So for including, so we make sure that patient leak to like mild to moderate leaking. So we include it in to our study. And then we treat the patient whether she going to receive the real treatment or the sham or placebo. So after we take a look at 12 months, you can see the sham group is much better. So, I mean, the treatment group is much better. It's 70% improvement compared to the sham group, which is only 38%. Okay, and this is another of my work. I just presented at IUCA this year as well, and hopefully it's going to publish this year, using the fractional bipolar radiofrequency versus sham for the vaginal laxity. So this is a RCT as well. So I used the vaginal laxity index as an indicator and include the patient who are premenopause. So because we already know that the energy-based device will improve postmenopausal women condition, however, we don't know whether it's going to improve for premenopause. So another outcome that we take a look is the vaginal. So the first one is vaginal laxity. So the score is improved, and it's significantly improved in the treatment group. And another one that we take a look is the vaginal thickness. We use transvaginal ultrasound, endovaginal ultrasound, 3D, and to measure like the thickness of vaginal wall. We measure anterior and posterior 3 locations each, and then see whether it's improved or not. So from our study is the thickness of vagina is increased 0.3 millimeters in the treatment group, and is significant compared to the sham group. And for the PGI, which is the patient satisfaction, is improved as well, is around 36% improvement in the treatment group. In terms of the safety, because energy-based device, the good thing is it's office-based procedure, is safe, and it's not different in terms of the adverse event compared to the sham group. Okay. So in terms of the guideline and integration, this is a summarize whether it's recommend or not. In terms of local estrogen, is recommend across the guideline, but for non-estrogen, so you can use other options like vaginal moisturizer, which is over the counter. You can buy anywhere, and it's okay. Maybe the first things that if the patient try to avoid using the estrogen, so it's maybe good for her. For energy-based devices, it's still like insufficient data, and right now it's like recommend as for the research only. So hopefully after like it's come up the market, it's going to be like more evidence. Okay. And for new trends of the treatment of the GSM, so mostly not going to use only one single modalities. So it's going to be combination. For example, so use the hormonal treatment with the local estrogen first for the patient who have GSM. And if the patient have very severe GSM, I almost always use local estrogen first before apply the energy-based device. Because if you use energy-based device at the beginning, so the patient may feel like very dry or discomfort during the treatment. And another thing is the pelvic floor. So we talk about like the first layer is vaginal mucosa, and the second layer is like lamina propria that like underneath vagina that use energy-based device. The last part is the muscle. So because after we go through menopause, the muscle kind of relax, and it can cause the vaginal laxity. And the thing that we can treat is the muscle. So almost always teach the patient how to do Kegel exercise or pelvic floor muscle training. And we also have like new innovation like the magnetic chair or electrical muscle stimulation that can like help the patient know how to contract the muscle correctly. So other than that, I also work on many research projects about the PRP injection. So I did the first RCT for PRP injection, comparing like pelvic floor muscle training in patients who have stress urinary incontinence, and it seemed like more than 80% improvement. And other than that, I also like have the application that teach the patient how to contract the muscle. So we can use like for the clinical study. Okay. I think for the new trends that we can integrate into our practice is the regenerative biology, like the PRP injection, exosome growth factor, or even stem cell. And I think for like energy-based device, gonna be like many more come up. And for the hormones device synergy. So hormone is still like the standard treatment. So don't forget to use the hormones for the local estrogen. And for the patient, it's not like everyone gonna receive the treatment like as the same. So you have to customize whether which option it works best for your patient. So in terms of take-home message, so female aging is a hormone and structure, so treat it like continuum and not only one symptoms. Local estrogens remain the evidence-based foundation for the GSM. And for the energy-based device, I think it's good for the GSM, stress urinary incontinence, and vaginal laxity. And it's still like ongoing for the research. So if you would like to use energy-based device, though you have to discuss with the patient that it's not standard yet, however, it's gonna be like maybe benefit for her if she want. Thank you. If you have any questions, feel free to contact me.
Thank you very much. I think it was a very important session, and we covered, I think, a lot of aspects. We have a lot of questions unanswered yet, so we'll leave it for the next year.
Yes, sure. And if the audience have some question, I know it's late, but we are in a small, intimate space, so you can ask your question. I have one for Rawi. You talked about PRP, and I also learned about using PRP to stimulate the ovary to function again. I know that it's still ongoing in Greece, for example. Do you have some insight about it?
Okay, so for the oral injection, right? So mostly for the reproductive endocrinology and infertility doctors who use that. But for my part, because I'm urogynecologist, I always use inside vagina, and also for the sexual dysfunction, like the O-shot, G-shot injection.
Actually, I have a question about the sensation with energy devices. We did some study long time ago, and the women said, oh, we're very happy that, our husbands are happy, basically. But when you looked at whether they had changed their lives, so there was the sensation was enhanced, the sensation actually was much less. So what have you found? Because our sample was kind of small, so I want to know more about what you have found.
So for like the FSI score that I collect, it's improved a bit, but it's not, not all domain. They don't feel. Yeah, so the sensation is not different. Yeah, like I just said.
How did you perform sham procedure with RF? I don't get it.
So when I do for the first one, I do with monopolar RF, like with the brand Viviv. So I contact the company to make the sham for us. So the sound is the same. The feeling that I insert inside vagina is the same. However, when I press the light button, it's no energy delivered. Yeah, and for another one is the fractional RF, which is the Morpheus XV. So I asked the company to produce the sham as well. And when we deliver, just like tiny, less than 0.01 centimeters of the needle that come up. So most of the patient doesn't feel anything.
Thank you. Yes?
Yeah.
So, can you hear me? Yes, Ron Fine from Sydney. Two questions. I didn't think I heard anything about topical estrogens on the face.
I mentioned it.
You mentioned it? Okay. But is there any feeling among the speakers in this regard?
So when we're talking about topical estrogens, first of all, keep in mind that it's nothing registered, nothing approved. So the safety is the major thing. Because when you apply estrogen topically, you still some of it is absorbed, so you can still have the uterine issues. So this is something that you need to keep in mind. I know that there's currently in social media a lot of women are taking the vaginal creams and they're applying it on the skin, on the facial skin. We need to be a little bit careful about it. There are some cosmeceuticals, especially in the USA, there are at least 3 studies that they published estrogen-like ingredient that is registered as a cosmetic ingredient, Zoedrylus. There are some studies that are not very, very convincing.
Okay, I'm talking about vaginal estradiol using the vagina, put a little bit on the skin, on the face.
Yeah.
So is any experience with that among the panel and speakers, apart from you,
Oh, no,
Marina?
safety is a problem.
Yeah, I
There
get
is
that.
no studies comparing, for example, topical estrogens with retinoids.
Sure.
So if they provide the same outcome, why to use something which safety is not proven
Sure,
yet?
I get that.
So there's a lot of questions and
Sure.
very few answers. But yes, it's one of the direction. Actually, I was thinking about the threats, why to cover the site with HA, let's put a little bit of estrogen in.
Sure. The second part of my question is energy-based. I've been using, until recent times when it was FDA or TGA in Australia eliminated, I had great results with radio frequency. I have so many emails from women who changed their life, really, from not being able to exercise due to stress incontinence to virtually having almost no stress incontinence. And it's a real shame that this has been withdrawn. It's a safety issue again, but I'm hoping that the research that you're doing and others will reinstate that possibility, because it really made a difference.
Yeah, so I would agree with you that many countries, especially Australia, so they withdraw like the energy-based device to use in the country. So I think it's effect for the women health. So some of the patient, like she cannot use the estrogen, or even she try and it's not getting better. So energy-based device is an option for her. And I would like to emphasize the local estrogen, vaginal estrogen cream, whether used for the skin. So I always use for the patient who have the skin condition like the lichen sclerosis. So I think it's, I'm not sure for the face, but for the genitalia, outside the genitalia, it can be used, especially in the patient who have postmenopause, or if the patient have like very thin skin and have like recurrent tear at the posterior forehead. So I think local estrogen play an important role.
Just to know that the general audience here, because the registered treatment for lichen sclerosis is topical high-potency steroids. So it might be some kind of other option. Thank you very much. I think that we conclude
Thank
the
you
session.
so much.
And
It was a beautiful
yeah.
session.
Thank you.